So I was just commenting about the distribution of different dementias. Um, I thought it was interesting. There was a report in the news literally yesterday that from a neurology meeting in the United States that was indicating that there's a blood test that's been used to detect amyloid and tau proteins in the blood, and it has a 90% accuracy for identifying um, dementias, particularly Alzheimer's. It's not clear whether it's associated with the other dementias. Um, so depending upon your etiology, this blood test may be right half of the time. But stay tuned. It'll be interesting as to whether these blood tests can identify risk factors for future dementia. So as an exercise, I like people to think about the different behaviors that are associated with dementia. I think what comes to mind obviously is, the agitation, but there's also hypoactive behavior. There's perseveration, there's hallucinations, delusional behavior, and a variety of at least a couple of dozen different behaviors that we can talk about. So one of the ways that we can measure these different behaviors is through the neuropsych inventory. And as you might surmise with this cartoon here, this poor fellow has got somewhat of an obsessive compulsive disorder, where he's washing his hands, dries them off, looks at them again, and he's got to wash them again. So this is an example of the neuropsych inventory. And the reason I'm showing it is it's a little maybe small print, if you can see it, but it goes down a list of a healthcare provider checking off the severity of the particular behavioral. So if they're having delusions, is the severity on a 1 to 3 scale mild or very severe? And pretty much how is that affecting the patient? And then on the right side is a measurement of distress. And the idea there is that does the experience of that symptom, how it affects you. And so you rate that on a 0 to 5 scale. So this is a formal methodology. It's used in research, but it can also be used clinically. Obviously, there's a variety of different things that have to be marked off on this, but if you're involved with older adults that have behavioral disorders due to dementing illnesses, this could be a good form to measure from week to week, maybe month to month, to see if your therapies are making any difference. So obviously, the lower the score, the more effective your therapies are going to be. So the distribution of these symptoms, these neuropsychiatric symptoms or behavioral disorders, they're plentiful, right? So if you look at the bar graph on the right side here, you can see that the total score for behavioral disorders affects up to 90% of individuals with Alzheimer's disease. And that the distribution is pretty even throughout. So half of the individuals here, you can see under agitation, this third set of bars, is up to 50%. And the points during their dementing illness that these come up can be pretty much an equal chance. So you can get agitation or you can get hallucinations as much as early in the disease, as well as you would in the middle part of the disease, as well as in late parts of the disease. Most people think that, you've got to have dementia for like end stage dementia to have all these disorders. And they can show up basically anytime. And they come and go. And so here's an example of the different types of dementias and the types of symptoms that are more commonly associated with it. So you can see here in the first column, Alzheimer's disease is the granddaddy of them all, dementias that has just about every type of issue known or described. But then you look at minimum cognitive impairment, it may be a little bit subtle. It may start off with depression or apathy, and those are the most common symptoms. And then you progress to Frontal temporal dementia, you can see that people might be irritable, leave me alone. They become more recluse, perhaps, and or they might have some issues of social inappropriateness, as we'll see. So this is just to remind us that there are different parts of the brain that are associated with these different feelings and behaviors. So I wanted to, in the spirit of our ECHO program, provide a case report here. So this is a 64-year-old lady who works as a project manager, and after 10 years on the job with excellent reviews, she received an end-of-the-year reprimand with a personal improvement plan that indicated concerns about physical appearance and hygiene, inappropriate comments, and low enthusiasm for her work product. At the physician visit, the patient is described as being unkempt. There was an inappropriate comment to the physician that looks like a good kisser. The physician was male. The blood pressure was slightly elevated, 155 systolic. Patient found to be oriented. There's no cogwheeling, no back propulsion, indicative of Parkinson's. Basically, the neurologic exam was intact and did well on the slums test, so 27 out of 30, which would be a normal score. The Sharpen-Romberg balance test was found to be abnormal, so her tandem stance was not able to be sustained for 30 seconds and had a flat affect. So if you have any thoughts about what's going on here, perhaps we can put that into the chat box. So which one of these do you think it's most likely? Okay, whoops, I went too fast there. Yeah, so this would describe frontal temporal dementia. Remember from that little table that I showed that apathy could be one of the first indicators, but it's also lack of awareness. These people do things and they just don't seem to think of any consequence, or they don't have any concerns. So there was a famous comedian that had frontotemporal dementia. It was Terry Jones of Monty Python. And just to describe the frontotemporal dementia, again, the almost sine qua non of this dementia is social inappropriateness. They exhibit poor judgment. They may be and you see this in all the dementias where they have, they may be spending money, or they may make friends with somebody online that is, trying to extort money from them. They have, this is really interesting, they have compulsive disorders, so tapping the foot or clapping. So I always worry about that when I see people, with shaky legs. There's a sense of overeating, and I guess that applies to a lot of us, right? But good gracious, that is one of the FT dementia symptoms. And again, poor hygiene. They also have, sometimes in extreme cases, they'll have what's called hyperphagia, where they eat inedible objects. You also see that in Parkinson's and progressive supranuclear palsy. So just to reiterate, there may be a sudden onset of weight gain. So if you have somebody with a behavioral disorder and just has this massive weight gain, you could start put 2 to 2 together that it might be frontotemporal dementia. The sweet fetish, well, one of the things, and sugar is the enemy, and just as a reminder that Alzheimer's is accelerated by diabetes, and so insulin insensitivity and resistance and sugar are part of the spectrum of disease progression, and particularly in Alzheimer's. And just to reiterate these repetitive behaviors, compulsive behaviors that might occur. the social inappropriateness. So sometimes it could be verbal, sometimes it could be physical. They'll get into your space and try and make a point, things of that nature. So moving to Lewy body dementia, any thoughts about who played Mork and Mindy? This individual had Lewy body dementia, and it was Robin Williams. And so the identification of Lewy body dementia are associated with movement disorders. And so it looks like Parkinson's, right? You get the shuffling walk, you might have a tremor. And a lot of times people come in with falls. And so it's always one of my high priorities in our fall clinic here at where I'm working at Sanford Fargo with our specialty clinic in falls one of my first questions is, do they have any cogwheeling? Because I'm really concerned about early onset Parkinson's disease or Lewy body dementia. And just to mention, Lewy body dementia is one of those dementias that goes really, really fast. And so it's a scary disease. It's a really rapidly debilitating disease. Some of the attributes, again, are loss of coordination. You can see that, what is often associated with Parkinson's is this micrographia. You can see this fellow here. He has a masked face. He's just kind of staring off into space. Sometimes people describe swallowing difficulties, and they may also describe that people don't seem to be able to hear them because they are what we call hypophonic. They're very soft-spoken. A big feature of Lewy body dementia are hallucinations, and it could range from all the senses, including olfactory hallucinations. Like I say, it's about 80% of the people affected by it. There could be delusions, with suspicions about spousal infidelity or thievery from family members. It's very disturbing because, the accusations go against the family members. There could be restless sleep, kicking, punching, and yelling in the middle of the night, and then it's accompanied with insomnia. And sometimes this could be associated with falling asleep at the wheel. I actually was involved as a expert content witness, medical legal witness for or consultant for a case where somebody had narcolepsy, but also apparently progressed to Lewy body dementia. This is true with a lot of the dementias. There could be listlessness, apathy, lack of interest, don't want to go out, don't want to be involved, and then also depression. There's a roller coaster of attention. Sometimes they'll just like stare off into space. It almost looks like they're having a temporal lobe seizure. And on occasion, I've treated these people with anti-epileptics, not really knowing whether they're having temporal lobe seizures or not. And a lot of poor judgment, similar to the frontal temporal dementia. They just make bad decisions. They may perseverate. A lot of that perseveration, where they keep repeating themselves, can also be seen in Wernicke's encephalopathy. So, B12 thiamine deficiencies. So there's always overlap, between these different entities. There's kind of the gesture of hand wringing. Might be something that they'll tip you off to Lewy body dementia. They just don't seem to be able to get settled. They're always kind of like moving around, but they're having difficulties moving around, and they fall a lot. Okay, so moving on to Alzheimer's dementia. Again, it's the kitchen sink with all the different kinds of dementias. I was kind of interested in chat GPT generation of PowerPoint slide pictures, and this is what I got here. This is supposed to. So I typed into chat GPT, give me a picture of a older couple where the wife has dementia and is concerned about spousal infidelity, and so you can see the husband talking to this younger neighbor. And that was about what ChatGPT produced. So kind of interesting from perspective of how artificial intelligence deals with some of these topics. So when individuals have these delusions. The first thing is not to get offended, because a lot of time family members just will react. They'll say, "Mom, that's not true." They'll reprimand them. And so the idea is that you don't really confront on this. You just try to do some reassurance and express your caring perspective, and that you'll try and help them solve this. Again, don't argue or try to convince anybody. There's no rational conversation. You're not going to be able to reason with people with dementia. It's always about acknowledging and recognizing their concerns. And then a lot of times you could just say, well, you can you may be right. Let's look further into it, and that's about it. And then try to switch your focus. And so you want to divert. Maybe it's let's go see if we can get some lunch made or something to that effect. And then finally, if they say that they've lost a wallet, if you find it, you can always put it back. If not, you can always have. I had a patient whose son had like a dozen wallets that he kept, or purses for his mom, because she kept losing her purse, and he would just put this, so he bought them in bulk. And it was always the same item, right? She didn't really get concerned about other items that were misplaced. In terms of aggression, it could be a variety of ways, and really the passive aggressiveness, they just kind of are stubborn. I kind of liken it to the old mule that just won't move or budge. And so the response to agitation is to firstly try to identify the cause, and you want to make sure that the individual is not in danger. When they're agitated, are they going to hurt others or themselves? And so that's really the first order of business. Is to recognize as to whether that behavior has any danger associated with it, and then you try and drill down to the cause. And really a big item in research is that agitation in dementia is associated with unresolved pain and distress. And so physical pain can come in many forms. Could be shoulder. And so you look for, as you're examining the older person, and part of the issue is that they may not want to be touched. And so, a physical touch and confrontation early on in agitation, not a good idea. So you might want to start the inquiry about, do you have any pain in your shoulder, your knees, or your back? Is anything hurting you? So at least just initiating the conversation. And again, that helps divert, their agitated response. And again, the idea is that you try to work with the emotion and not respond to the explosion of behavior. And in this instance, this pictorial display here is that the woman who's the caregiver is trying to remain neutral. Don't have furrowed eyebrows like this guy has. In fact, maybe raise the eyebrows, or at least try and keep them neutral, because 60 to 80% of communication with people in general, let alone people with dementia, is nonverbal expressions. So some of the other ideas is to add relaxation activities. Again, the sense of touch is kind of a touchy, touchy, that's the wrong word to use, but it's a touch and go issue. In terms of responsivity, because sometimes the agitated individual is not really responsive to the sense of touch. Sometimes they are, and so it's a trial and error. Diversions always. Food is usually a good one. Try to, if you have to, step away from the agitation and just let them know you'll be back, and just ask them to take some deep breaths. And then again, if there's inability to calm the person down, and if there looks like imminent harm to self and others, which is always the highest priority evaluation, then you call 911. Anxiety is perhaps the most prevalent issue that confronts older adults in general, with or without dementia. And so the response to people that have anxiety, would be to try to reduce caffeine. I just listed there the coffee, colas, and chocolates have caffeine. And the thing about aging is that caffeine stays in your system for 24 hours. So if you have a cup of coffee in the morning with caffeine, it'll be with you till the next day. The other approach is to try to change the environment. If they're in a group dining room and it's a little too loud, maybe taking them out of that area or having them have their meal in their own room. There's the possibility of providing a security blanket or a plush animal, sometimes dolls. Um, and then also trying to have a timeout. These are all techniques that seem to work to help reduce anxiety. And again, checking for physical comfort, right? So you always want to make sure that they're comfortable. Constipation, even obstipation, if they haven't had a bowel movement, can be a source of both agitation, delirium, as well as a full bladder. And sometimes people have urinary retention, and that needs to be evaluated. So one of the axioms is always listen before reacting, and then asking for permission rather than making statements. Just asking, "Can I help you?" Try to use a calming voice as best possible, and then also trying to reassure and just acknowledge that they're having an issue. So try to offer simple choices. Don't, yeah. So just ask them, do you want to go for a walk or do you want to go back to your room? Or do you want to see your daughter or do you want to see the nurse? Something like that. So with hallucinations, there could be a variety of things that people imagine in their heads. A lot of times, shadows will precipitate these kinds of um, hallucinations. You could have auditory and visual hallucinations. Remember, you can also have olfactory hallucinations. Smells like the place is burning down, something to that effect. The cause of hallucinations can be neurosensory impairment. Maybe just simply that they've got lost their glasses, or they may have earwax impaction. Medications are probably the biggest culprit. I list here diphenhydramine, which is Benadryl. That's got anticholinergic properties, and that a lot of times will be the precursor to delirium. In terms of these hallucinations, you want to establish how upsetting the situation is, because sometimes the hallucinations are just, oh, they're there and, they've been there and they're not bothering them that much, to a point where, they're really quite disturbed or concerned about the hallucination. So, like the other types of behaviors, you acknowledge what's going on. If they are seeing something, you say, yes, okay. Um, and you'll say, I'm not quite sure I see what you're seeing, but let's look into it further, and go from there. So it's always about an acknowledgement. Again, be careful with the physical encounters with the older adult with dementia. Sometimes physicality can further escalate some of the issues. And so it's either through gentle touch or through just kind of steering the patient with your body, without grabbing them, but, trying to move them in another direction. It's also important to try and figure out over time, whether there's some specific triggers. And so I've put here a pineapple, which to a World War II veteran, back when World War II vets were around, and maybe even Korean vets, this looked like a hand grenade. And so we had a specialized VA Veterans Administration unit that I used to work in, and we had to we had a South Pacific mural that had a bunch of pineapples on it, and one of our patients was just freaked out seeing these things, and so we had to cover up the mural, to acknowledge his triggering moment there. So again, that was an example of modifying the environment. Sometimes maybe more distributive lighting to reduce shadows. Removing mirrors might be another possibility. One of my favorites was a story about a retired lawyer who had dementia, and he kept trying to leave his house to catch a train to downtown Chicago from the north suburbs. And so finally, his caregiver told the spouse that maybe let's just put a sign up that says the trains aren't running today. And so that actually worked out pretty well for reducing the behavior. He was also caught leaving the house one time, and another technique is just to let them go until they discover that they're you know they don't know where they're going, and so then you come up to them and you say, can I help you, and get acknowledge sometimes that they're having a problem. The depression and apathy is always a tough one to deal with because you want to get people going, but they just they don't have the drive, and they may resist care. Don't bother me. This, by the way, don't bother me could be a source of hypo active delirium, and so you have to distinguish between apathy, depression, and delirium. So this idea that they're just kind of sitting like a lump on a log. If that's new behavior, you have to rule out hypoactive delirium in the first instance. A lot of times, depression will precede dementia. That's why a lot of patients who progress to dementia are on SSRIs. And boy, oh boy, the SSRIs, these antidepressants, really escalate from a provider's point of view, because you've got one SSRI that you're going to give for depression or low mood. You're going to give another one for sleep, and then you're going to give another one for appetite, perhaps. So I've seen people on 3 at least SSRIs, and I just never really quite fully understand it. The other part of the depression is that people can't focus and stay concentrated. They may lose interest in their hobbies. Although sometimes the loss of interest in the hobbies is because of neurosensory problems. I worked with, or encountered at the time, the oldest veteran in North Dakota, and he was just about to turn 100, and he was in the veterans home. And I said, "What do you like to do?" And he's, for a hobby, and he says, "Oh, I do woodworking, but it's kind of rough. My hands are too arthritic, and I just think I'm going to have to let it go." And I said, "Oh, good gracious." I said, why don't you get a young apprentice, one of these 70-year-old guys here, and help you out?" And so he liked the idea and got on with his hobby of woodworking with one of his younger apprentices. Some of the non-pharmacologic interventions for depression associated with dementias are to have a recurrent, predictable schedule, making lists of things, always trying to engage in physical activity, trying to do positive reinforcement for things that that they're active with. So if they go out for a walk, so this is, compliment them on going out for the walk, and, let's look forward to this for tomorrow. Try to engage family as much as possible. If there is no family, then trying to get some volunteers that are connected. I know my experience back in Chicago, they have the Little Brothers and Sisters of the Elderly, which is a volunteer organization. So something like that would be beneficial. I put down at the bottom here that psychology as an adjunctive therapy is important. So it's always important to consider that you get better outcomes with depression in general, not just with demented patients, but if you prescribe psychotherapy in addition to medications. Yeah, repetition here. So we got the Andy Warhol, lots of different types of soup here, ranging from split green pea to chili beef. So take your choice. Oh, and my favorite, minestrone soup down there at the bottom. So in terms of repetition, you want to kind of get the cycle. What is the pattern going on, and try to also understand or appreciate the feeling that the individual's having. Again, is it related to pain, distress, or other concerns? And then, if you can, try to be creative and get the behavior um, into some sort of meaningful action. So here's a good example: if they're rubbing the table or patting the table, or rubbing their leg or something like that, you get a dust cloth or something to that effect, to replicate the behavior, but in a purposeful way as best possible. And the bottom point here of toleration is, again, um, don't chastise, don't admonish, don't reprimand. No matter what behavior he has, you don't want to confront the person because it will only escalate. And again, don't use logic, don't use reason, because there is no logic or reason. I was going to make a comment about our government, but I'm not going to do that. Other response to repetition, use memory aids. So things like little stickies, um, calendars, photographs are very, very good. And you'll see a lot of assisted living facilities or even skilled nursing facilities, and some hospitals will put pictures on the door of either the individual, the patient, the resident, or their family member. Wandering is always an issue throughout, no matter where, whether it be in the nursing home or at home. A lot of times you have to have a game plan, for dealing with wandering. And so you want to let neighbors know about the possibility, and to make sure they have your phone number, make sure the individual has an ID bracelet. Always have a photo ready of the person, a current photo. Now, like one time I got a photo of this middle-aged looking person. I'm going like, who's this? You have to have a current photo. And then also identify places where the person likes to visit. So they may walk to the coffee shop or something like that. And that's been a routine of theirs. In terms of trying to reduce wandering responses, having structured activities, again, making that list, the schedule of things to do, trying to avoid nighttime. So I usually tell people after dinner, no liquids, no water or things unless absolutely necessary, because once you have to go to the bathroom in the middle of the night, that could be a source of wandering. If you can get GPS monitors, those are always helpful. You have to be particularly, if somebody's, so people with dementia can drive if they're early on in the dementia and if they're approved, so they have to be evaluated. And it may depend upon the setting. If they're in a rural area, it may be less of a concern about driving with dementia than in the city. But that's always a case by case basis. We use occupational therapy driving assessments to really help us understand their sense of judgment and sense of adaptation. So people do adapt to disabilities, including cognitive disabilities, but there does get to be a point where they're not able to functionally drive. So if you have some level of independence with the older adults, so if they're early in their dementia, you might want to have times for them to check in, calling them, touching base. Again, the schedule. It's always important to have a buddy system or a companion, and also try to promote alternative transportation, because a lot of times people perseverate on the driving. They want to drive, and that really becomes a repetitive pattern for them. Some of the ideas for wandering with more advanced dementia. So in memory units, they'll have a special lock door where you have to press or hit buttons to get out. It's good to have night lights, perhaps cloth covers over doorknobs, so they can, if it's a round knob as opposed to a French door knob, right? And doing different kinds of environmental modifications. You could have warning bells, if they go through a certain door. or open the outside, the door to the outside, and also having safety gates. So if somebody does go missing, they'll always generally follow their dominant hand. So if they're right-handed, they'll go to the right. If they're left-handed, they go to the left. Um, most demented patients are found within 1.5 miles of their original location. So again, just geographically check fence lines and brush borders because they tend to follow um, objects, through their meanderings. And they probably will go to the same site where they had been found before. So that's always a thing to consider. And then contacting the police if they're not found within a reasonable amount of time. Okay, so let's look at this case vignette. You have, let's see if I can hang on for 1 second here. I've got to move my chat box here. So you have a phone call from a husband, 82-year-old patient with moderate dementia. Over the past 5 days, more confusion, more agitation in the evening, and attempting to leave the house, sleeplessness. So the question here is that you don't really want to assume anything, and it's important to ask a lot of questions about the behavior. Is it new? Are there any new physical symptoms? Any recent falls? Have there been changes in the environment or caregivers, for example? You also want to ask in this instance, any new medications or change in medication dosage, or has there been a change in alcohol or even smoking, for example? Did they stop suddenly and maybe they're having withdrawals? So these are all kinds of lines of questions that you want to ask. You also want to see if there's any ongoing pain that perhaps got worse. And so is it known that they have pain perhaps in their shoulder or in their back? Are you noticing any grimacing, any facial expression changes? You also want to ask, is there any fever or cough, or are they still drinking water? A lot of times the biggest problems with older adults with dementing illnesses is they don't remember to drink enough water, and so they become dehydrated. And that dehydration may mask a fever or an infection. So it's sort of like a spiral, downwards, just because of their hydration status. And some facilities actually, long-term care facilities will offer, midday soup, water, beverages in the morning, mid-morning, mid-afternoon, and post dinner, and that helps keep people hydrated, particularly for those that are high functioning but still have memory disorders.
Dr. Gervich, we have a question.
Yep.
Michelle Hofstadard is wondering, working with someone who now has a lack of appetite and eating is not appealing to them. Just wondering if you had any suggestions on types of food to encourage and promote.
Yeah, those are always tough ones too about apathy with eating. So a couple of things. People with Alzheimer's don't have a good sense of smell, and so the food does not become palatable. That's number one. Number two, you have to look at the dentition and make sure that there's not either sores, ulcers, or reddened tongue, loose dentures, and coated tongue. And sometimes brushing the tongue can help with the sensation of taste. Also, thinking in those cases, if there's a sudden loss of appetite, whether they're there might be some other, like a runny nose, you have to think of COVID, which is another, differential diagnosis for loss of appetite. It also could be a vitamin deficiency. And so, taking for an evaluation. Sometimes the stimulants that people use, which are not real well proven, but low dose mirtazapine has been used. Um, 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 Different products of cannabis, CBD, um, has also been used with various levels of success. Um, and then also trying to identify food preferences, right? So if they like chocolate, go with the chocolate, right? It may not be the best for them, but that's pretty much the way you get the appetite at least stimulated. So it's a little bit of this. Small frequent meals is another intervention. So I hope that gives you some thoughts about how to approach it. It's not 100%. All right, so I wanted to move to case two, and we can just open this up for discussion. Also, there's a 78-year-old retired lawyer with Alzheimer's. He's fixated on, and this is actually a story I told you earlier about catching the train to his office. He attempts to leave the house to go to the commuter train. On one occasion, he leaves the house and is quickly found at the end of the block, looking confused and frustrated. So what kind of behavior is this? Oops. I have a Surface Pro computer, and when I hit certain areas of it, it does things I don't want it to do. So I think we can agree that this behavior is um, wandering. And the question is, how can you prevent this behavior and better manage it in the future? And we explored some of those ideas about modifying the environment, um, trying to divert, right? So you modify environment, you divert, you have a schedule of activities, and what's the one thing that you're going to do? So if this guy wants to go, downtown, you say, good, we'll go later. So you acknowledge that he wants to go. You don't say, Dad, no, you don't need to go downtown because you're retired and you haven't been practicing law for 20 years, something like that. You don't want to chastise them. You don't want to admonish them. Have another example here of an 82-year-old with mixed dementia. He's uncooperative with showering. And so question is, how would you manage his hygiene? Um, does anybody have any thoughts about this? If you want to unmute yourself, that would be good. Anybody have any insight as to how you would handle this guy who doesn't want to get cleaned up? Okay, I'm not seeing any takers in the chat either. Um, so, okay, thank you, Heidi, for that. Offer some kind of reward. That's good. So you kind of, try to entice them, some incentive, come back later. This is good. Um, yeah, and I think and Amberly's really hit the nail on the head, is that you want to try and just do what we call geographic or regional cleansing, right? So you just, maybe just work with the hands, and if they allow you to, do face hygiene, trying to looking at the biorhythm, looking at different times of the day, yeah, and just going as much as we'll allow, and then readdress it next time, as Lacey's pointing out here.